Hello students, welcome to EPG Pathshala. I am Dr. Renu Tyagi from Sardar Patel Institute, Ahmedabad. Today we'll study the module, the interrelationship of body measurement with the respiratory functions under the paper Physiology and Sports Anthropology. Now let's see what we are going to learn from this module. The learning objectives of this module is to have an introduction of the lung functions and to have an idea about their different types and how we measure the lung functions. Then it will be followed by a discussion on the factors which influence the lung functions. Then will follow the study of variations on the various respiratory functions on the basis of changes in our age. We'll also have a look at the changes in the respiratory functions on the basis of changes in the body size or depending upon our obesity level and depending upon the different circumferences. Then at the last, we'll try and understand our relationship between the respiratory functions and the body measurements. Now let's have a look like what is our respiratory system is basically made up of and how does it respond to the environment and how does our lung functions varies with the changes environment and to what extent that relationship takes place in the environment and our respiratory system, mainly our lung functions, that is the lung volumes and lung capacities. As we all are now familiar with the concept that lungs provides the gaseous exchange surface between the environment and between our body, that is between different respiratory body parts or the alveoli in the lungs. Lungs have an extremely large surface area for the gaseous exchange because of the different or several alveolar sacs in the lungs, which have a kind of shape that gives a huge area for the gaseous exchange in our body and the environment. We know this pulmonary ventilation functions primarily to maintain a constant and favorable concentration of the gases, especially the oxygen and the carbon dioxide in the alveoli during the rest as well as during the exercise. So our lungs maintain a kind of balance of the gases, that is the oxygen or the giving out of oxygen and breathing in the CO2 in our body. The pulmonary ventilation is a process by which the ambient air is moved into and exchanges with air in the lungs. The oxygen transfer from the alveoli to the blood capillaries and then CO2 transfer from the capillaries to the alveoli. Each minute at rest, the pulmonary ventilation is 250 ml of O2 and 200 ml of carbon dioxide diffuses in the opposite directions. During inspiration, the diaphragm descends, the ribs are raised, the volume increases and intrapulmonic pressure decreases. Therefore, the air rushes in and as a consequence, the chest cavity size increases. Contributing muscles during the inspiration are external intercostal, sternocleidomastoids, scalenes and spinal extensors. The expiration or exhalation is a passive process wherein the diaphragm relaxes, the ribs are lowered the volume decreases and intrapulmonic pressure increases. Therefore, air rushes out. As a result, the chest cavity size declines. The lung volumes vary with the age of an individual, the gender, body size or dimensions, our body composition, and our stature. The lung volumes or capacities, for instance, the functional residual capacity is reported to be small among infants. The respiratory functions depends on the body size, and during childhood, after allowing for the effect of body size, is nearly independent of the age. The size of the lungs determines the respiratory function such as total lung capacity. In children till puberty, the indices, for example, the forced expiratory volume, are related to stature in a curvilinear manner. A linear relationship on height raised to the power of about 2.6 logarithm are used to analyze the relationship between the lung size and the respiratory functions. Now let's understand what is the spirometry. As the name suggests, spirometry is the measurement of the lung functions. With the advent of the spirometer in 1846 by Hutchinson, the vital capacity and lung function testing came to the forefront. During the World War II, the pulmonary function test PFT assumed a vast practical importance and a rapid progress is ensured. The progress has then steadily occurred with constantly improving investigation techniques and the equipments. Since last few decades, the pulmonary function tests have gained importance to add to the clinical practice of medicine. At present, these tests are routinely used to evaluate the effectiveness of therapy, to assess the diagnosis, to assess the prognosis, and thereby determine the disability. The technique of spirometry is quick, non-invasive, and painless. Therefore, it can be used in the practical aspect or for the practical purposes very wide sense. We can measure the different lung volumes and capacity with the help of spirometry technique. The lung volume measurement, whether it's a static or a dynamic, can help us to identify the potential obstructive or restrictive lung disease. The lung volumes varies with the age, gender, body size, and body composition, as we have seen it earlier. The static lung volumes provides us the record of ventilatory volume and breathing rate. The static lung volumes can be the tidal volume, inspiratory reserve volume, expiratory reserve volume, forced vital capacity, whereas the dynamic lung volumes can be the forced vital capacity. An adequate pulmonary ventilation depends on the ability to sustain high airflow level. So, the dynamic ventilation depends on the forced vital capacity or breathing rate. The high airflow level depends on the lung compliance. The other dynamic lung volumes can be the forced expiratory volume, minute ventilation. The aging and our lifestyle both influence our lung volumes and pulmonary functions. Aging and lifestyle influence the lung volumes. The various lung parameters measured can be utilized for the diagnosis of respiratory disorders and status of ventilatory function. Some of the important reasons for the decrease in the lung function with an increase in age are the change in the elastic recoil, the decline in the strength of the respiratory muscles. There is an increase in the stiffness of thoracic cage with the age. Besides, there is a decline in the permeability of the cell membrane. Among all, the residual volume is most affected due to the aging. The residual volume is 1.5 liter at the age of 25 years and it reaches up to about 2.2 liters by the age of 60 years. The ratio of residual volume to the total lung capacity is also affected with the age. It is reported to be about 25% at the age of 25 years, which may increase up to 37% at the age of 60 years. Now let's understand the influence of the lung volumes and its relationship with the stature. In human being, the most convenient indices of body size are weight and stature, but in the presence of stature, the weight is only weakly correlated with the indices of lung function. The size is better related to the indices of linearity. The body fat, which in large amount has an adverse effect, and the muscularity, which when it is increased is usually associated with the average performance. The stature is reported to be positively correlated with our lung size as compared to any other measurement. The relationship between lung size and stature is almost linear in adults, and for children, exponential model is suggested. It has been recognized that gender race differences in lung function exist as the lung functions are better in males than in the females. Let's have a look like how does the ethnicity brings variation in the lung functions. As we all know that ethnic group is a very important determinant of the lung size and the ventilatory capacity of our lungs. But it does not influence the capacity of the lung to transfer the oxygen into the blood. The capacity remains the same, but the lung size may vary. On the basis of ethnic origin, the lung sizes were found to be different. Studies of people of different ethnic group shows that there is to be considerable variation in the sizes of the lungs. Some of these variation could be the environmental, which may relate to the difference in the altitude or in the level of their habitual physical activity. For instance, the people who are staying at a higher altitude have a different lung size as compared to the people who are staying in the plains or the low altitude areas. Similarly, the people who are carrying out different physical activities have the different lung sizes. For instance, the athletes have considerable different lung size as compared to the normal individual. However, after allowing for these factors, related differences remains. They are associated with the other differences in the bodily dimensions, which are difficult to be quantified. The simplest approach is via the stature, which is expressed in these for the lungs of the ethnic variation is of the order of about 25%. But stature is the sum of the leg length and the sitting height, which varies independently in the people of different ethnic origin. For instance, the Australian Aborigines and the Negro people who have a small lung related to their stature have the longer legs and the shorter bodies than the people of Mongoloid, Indian or European origin. So that clarifies the smaller lung size among the people from the Australian Aborigines and the Negro origin. On this account, the use of the sitting height as the reference variable for the lung size reduces the dispersion between the group and which need to be or does not be eliminated. This may be achieved by relating the volume of the lungs to the anthropometric dimensions of the thorax or the chest. One of the study by the Rossiter and the Will in people of black and white origin shows or obtained a difference of about 13% for the vital capacity and the forced expiratory volume among the adults. In absolute terms, it represents an average difference in the forced vital capacity and the forced expiratory volume among men of 0.7 and 0.45 and in the women of 0.8 and 0.41. The maximal breathing capacity and peak respiratory flow rate may also be lower than for the Europeans of similar age and the size, but the differences are less. Some of the indices which do not appear to exhibit the ethnic variation, that is, there is no differences in the people from different ethnic background. These lung functions include the residual volume, that is the amount of the air which is left in the lungs after a forceful exhalation does not show much changes in the people from different ethnic background. Similarly, the specific conductance and the transfer factors. For the latter, that is for the transfer factors, the smaller lung volume is associated with the lower values for the diffusing capacity of the alveolar capillary membrane. But this is offset by the volume of blood in the alveolar capillaries being somewhat larger than for the European. The anatomical basis or the structural changes for this difference is not yet established. Now let's see the various environmental factors which influence the respiratory function of the lungs, which can be the physical activity level, the altitude, the level of air pollution and the smoking status. It has been reported that there is a considerable change in the lung functions at high altitude among human beings. As the first interface between the environment and the body, the lung serves a vital role in the transfer of oxygen from the air to the blood. It limits the response and adaptation of the lungs to this hypoxic stress, both at rest and during the exercise. When oxygen and carbon dioxide flux from the tissues is greater, the ventilation is described in the terms of hypoxic stimulus that cause an increase in breathing and the metabolic caused from the respiratory muscles anchored by this increase. Individuals at high altitude have a substantial sense of dyspnea, which in and of itself may limit the exercise tolerance. The function of the lungs is to exchange the oxygen and carbon dioxide, which it does at the alveolar capillary interface. Here, the important limitations are encountered because the driving pressure for oxygen from the air to the blood is lower, and the more rapid transit time of blood across the pulmonary capillary allows less time for equilibration of oxygen with the blood. Both these phenomena leads to a limitation of diffusion of oxygen across the alveolar capillary membrane and hence more accentuated hypoxemia. Now let's study the changes in our lung functions, especially among the children. In children till puberty, the lung functions are quite related to the stature. The functional residual capacity, for instance, is reported to be small among infants. The respiratory rate is also high. The weight of the infant as well as the age determines the consumption of oxygen. After stabilization of the functional residual capacity at birth, the ventilation minute volume and the alveolar ventilations are comparable to the adults when the difference in metabolic rate is taken into consideration. The respiratory function depends on the body size, and during childhood, after allowing for the effects of body size, is nearly independent of age. The size of the lung determines the respiratory function, such as the total lung capacity, a subdivision. The indices which are dependent upon the lung size, like the forced expiratory flow and the transfer factor. In children till puberty, such indices are related to stature in a curvilinear manner. A linear relationship on height raised to the power of about 2.6 logarithms are used to analyze the relationship between the lung size and respiratory functions. Now let's understand the gender differences in the lung functions. In relation to the stature, the boys and girls have the similar values for some lung parameters or lung functions. For example, the residual volume, the peak expiratory flow rate, and the peak expiratory flow rate at 50% of the vital capacity. The expiratory reserve volume is slightly larger and the inspiratory capacity is about 12% more for boys than for the girls. Therefore, the boys have the higher values for the functional residual capacity, the vital capacity, and the total lung capacity. The boys have a different lung sizes as compared to the girls. Due to these differences in the lung sizes, the boys also have a larger value for the FeV1. The difference in lung size between boys and girls also extends to the transfer factor and its subdivisions, the diffusing capacity of the alveolar membrane and the volume of blood in the lung capillaries. The transfer factor and lung volume is generally similar across the sexes. So the difference in transfer factor in boys and girls is solely due to the boys having the larger lungs. The transfer factor is on average higher among young children than among the adults, and during adolescence it declines towards the adulthood stage. On this account, the transfer factor is negatively correlated with the stature. The greater size of the lungs among young men as compared to the young women appears to extend to all its component parts, including the air sacs, the alveoli, and the air passages. The airway resistance of men is somewhat less. This factor combines with the greater muscular strength among men and larger vital capacity of men to give them the larger ventilator capacity. However, the proportion of forced vital capacity which can be exhaled is less for men than for women, which suggests that male airways may be more susceptible to dynamic compressions. As the lungs of men are larger than of the women, they are more compliant, but the values for both the sexes are similar when they are standardized for the size. Adult women consistently have a reduced lung size and smaller static and dynamic lung functions measures, reduced airway diameter, and smaller diffusion surface than men, even after accounting for difference in stature. This disparity produces expiratory muscles work and relatively greater use of ventilatory reserve among women as compared to men during a maximal exercise, especially for the highly trained women as to the trained men and less fit women. A relatively smaller lung volume plus a high expiratory flow rate requirement in demand on maximum flow volume envelopes of the airways, that is mechanical constraints of tidal volume and pulmonary minute ventilation. This adversely affect how highly fit women maintain alveolar to alveolar oxygen exchange, which could compromise arterial oxygen saturation to a greater degree than observed for men. Now let's have a look on the anthropological dimensions and their relationship with the lung functions. The pulmonary functions have been shown to correlate negatively with the age, while a highly positive correlation has been recorded in relation to the height and sitting height in both men and women. Among men, a positive correlation has been recorded in relation to the arm and leg length. The pulmonary functions of women negatively correlate with the body circumference. Studies correlating the trunk and vital capacity of young males proved that only shoulder width and sitting height are positively correlated with the vital capacity measurement. The vital capacity has correlation with many other anthropological dimensions and can be regarded as a indicator of body constitution type. A stepwise multiple regression has found that the body mass index and biceps skin fold thickness contribute significantly to the prediction of residual volume and total lung capacity. There has been found to be the relationship between the waist circumference and the derived measurements like waist hip ratio, body mass index, and the lung functions. For instance, there is a relationship between the waist hip ratio and body mass index with the forced vital capacity and forced expiratory volume in first second. It is reported that the pulmonary functions are negatively associated with the increasing quantiles of waist hip ratio, waist circumference, and body mass index after making an adjustment for height. The waist hip ratio in men and waist circumference in women were associated with a bigger reduction in the respiratory function. Now let's have a look on the lung functions and our posture. It has been reported that all the indices other than the FEV1 to FVC increases with the standing height. There has been reported to be a linear relationship in the lung functions with the sitting height. In the supine or lying down position, there is a lot of blood in the capillaries and the diaphragm shift towards head, thereby the lung functions reduces. The Mexos et al. In 2004 reported that the slumped posture significantly reduced the lung capacity compared with that of the normal, and the sitting upright with partially removed ischial support and the lumbar support. Now let's have a look on the influence of obesity on our lung functions. In obese people, the presence of adipose tissue around the rib cage and abdomen and in the visceral cavity loads the chest wall and reduces functional residual capacity, that is FRC. The reduction in FRC and in ERV is detectable even at a modest increase in weight. However, obesity has little direct effect on airway caliber. The spirometric variables decrease in proportion to lung volumes but are rarely below the normal range even in the extremely obese individual. Greater airway closure during the tidal breathing is associated with lower arterial oxygen saturation in few people, even though lung carbon dioxide diffusing capacity is normal or increased in the obese. Bronchoconstriction has the potential to enhance the effects of obesity on airway closure and therefore on ventilation distribution. Hence, obesity affects the lung function and it can reduce the respiratory well-being even in the absence of specific respiratory disease, and it may also exacerbate the effect of existing airway disease. So students, now let's summarize what we have learned in this module so far. Now we have studied the influence of the gender, age changes, differences in the height and differences in the ethnic origin and their influence on the lung functions. We have seen like how does the lung functions changes in the children and among the adults and among the elderly. And we have seen like people from different ethnic origin have the variation in their body dimensions. Similarly, the people of different gender, that is whether they are male or female, also have an impact on their lung functions. So these all have been described so far. However, in the studies observed so far, only non-significant association were reported between the body weight and the lung functions among healthy people after having accounted for the effect of their age and the stature or the height. However, few studies have considered the influence of body compartments, that is the lean and the fat mass and their distribution on the lung function and the respiratory gas exchange. We have seen like how does a lung function varies among the obese people and among the leaner people, which has an influence on our lung function or it adversely affect our lung functions. A review of the literature on the effects of body weight components and the body composition measurements on lung functions have shown the central fat or the fat on the upper body of an individual patterns of fat distribution to be negatively associated with the airway functions, and that an increase in the body muscular that results in the increase in all the spirometric variation or the lung functions in the healthy people. We have seen like how does the obese people have an adverse impact on their lung functions, that is the people who are having the obesity on the upper body part have an negative consequences on their lung functions, that declines their lung functions. And the people who are more muscular, who have more muscles, especially those who are athletes or those who are having a habitual physical activities, have an advantage and have a better lung functions. The spirometric variations in the healthy people have been seen. So that gives us an idea about the variations in the lung functions or on our respiratory dimensions with the changes in the age and with the changes in the gender or with the variation in our ethnic origin, and similarly it also helps us to study the variation in the people who are obese or who are leaner, have a different lung dimensions. Thank you.